We have listened to the talks on cellular therapy. So, transfusion-associated graft versus host disease and TRIM are also important to know what all effects can occur when we transfuse these patients with various blood components. So, coming to first of all, transfusion-associated graft versus host disease. So, I'll be discussing my topic under this headings. So, coming to an overview, transfusion-associated graft versus host disease is a clinical syndrome occurring from 2 days to 6 weeks after cessation of the transfusion, characterized by characteristic rash, that is erythematous rash, maculopapular eruption centrally that spreads to extremities and may in severe case progress to generalized erythroderma, hemorrhagic bullous formation, diarrhea, fever, hepatomegaly. So it's a rare complication due to the transfusion of lymphocytes containing blood products, that is leukocyte dose, and age of the component would also matter. And clinically similar to bone marrow transplant and hematopoietic stem cell transplant patients who develop the graft versus host disease. Usually it rises between 4 to 30 days after transfusion. Onset of the symptom occur early with signs and symptoms of bone marrow aplasia. So 50% of these cases occur who would not have predicted to be at risk for Gvhd by the current irradiation guidelines. And donor lymphocytes whose HLA antigens are all shared by the recipient dominate in the Gvhd cases. So coming to a background of for understanding Gvhd, we'll first understand what is graft versus host disease. So it's a phenomenon in which the donor T cells responding to proteins on the host cells proliferate, target host organs, primarily the skin, liver, intestinal tract, and bone marrow. And it can occur in hematopoietic stem cell transplants, also transfusion of unirradiated blood and blood components. So the graft must contain an immunologically competent cell for Gvhd to occur, and there must be an antigenic difference between the donor and the recipient. The recipient must be unable to mount an effective immunological response against the the immunocompetent cells. So rarely immunocompetent recipients can also develop this graft versus host disease. So there is a pathophysiology of Gvhd which says that first recipient conditioning occurs in the step 1. So due to chemotherapy and radiotherapy or both which lead to tissue damage, it will secrete the lipopolysaccharides, and this will first stimulate in step 2 the donor T cell activation would occur, which would directly cause the target cell apoptosis or would increase the donor T cells to secrete inflammatory cytokines, which will affect the effector cells in the third step, the cytotoxic T cells and the natural killer cells, which will again cause the apoptosis. So we'll understand what are the various mechanisms by which the activated T cells they cause this harmful effect. So it is Th1 cell pro-inflammatory, then activated T cells would cause Th2 cells anti-inflammatory response and regulated T cell response. Th1 pro-inflammatory response will secrete these harmful inflammatory cytokines, which would result in the graft versus host disease. So this is another review article which shows the various donor and the recipient cells, and the donor cells when transfused, they cause various effector mechanisms by which Gvhd would occur. Now, understanding Gvhd, it is also important to understand by depleting all the T cells, we are at loss again. So unselective depletion of T lymphocytes would increase the risk of reoccurrence also. So breast protection would be against leukemia and against the reoccurrence. So graft versus host disease would have an anti-leukemic portion also, which would we call the graft versus leukemia effect. And we have to balance the dose of T cells which are being given so that the Gvhd would not occur and GVL would occur. So pathophysiology in case of transfusion-associated graft versus host disease, when we give the transfusion, the donor T cells, basically, if the donor is homozygous and the recipient is heterozygous for the HLA haplotype, especially the class 1, the host will not recognize the donor lymphocytes as foreign, whereas the donor will mount an immune response against the recipient. There are various mechanisms by which the donor T cells will proliferate in the recipient. So this is the activation of T lymphocytes, proliferation and migration, the massive release of TNS alpha, IL-1 and 2, Then TNF alpha key inflammatory cytokine. So this causes activation of dendritic cells, recruitment and further activation of T lymphocytes, that is the effector cells, and which would directly cause tissue necrosis. So then, what are the effector mechanisms by which the T cells cause the apoptosis? So most commonly, the effector mechanisms are the perforin granzyme pathway by which the cytotoxic T cells cause the apoptosis in the target cell. Another mechanism is the fast ligand and the fast receptor pathway by which the FAD is activated and various caspases are activated, which cause apoptosis. So then coming to factors for developing transfusion-associated graft versus host disease. So we have discussed one main factor is inability to reject the donor T cells, which is the main factor. Then degree of population genetic diversity and HLA homozygosity. And then what number of T cells would the viable T cells would cause the TAGVHD. So there are some studies that indicate fewer than 10:5 T cells per kg. It can also occur at low dose of 10:4 and usually at doses of 10:7 T cells per kg recipient body weight. So cardiac bypass surgery is another risk for transfusion-associated graft versus host disease. In cardiac bypass surgery, so we'll also discuss this under the TRIM effects: increased mitogenic lymphocyte transformation, increased production of cytokines, that is TNF alpha and IL-2. And TAGVHD has also been seen in extracorporeal membrane oxidation cases. Fresh blood contains maximum number of viable lymphocytes. Blood less than 4 days old, lymphocyte viability is retained in the stored cells. Then patients at risk of developing transfusion-associated graft versus host disease, recipients of donations from first and second degree relatives, patients receiving HLA matched components, all T lymphocyte immunodeficiency syndromes, intrauterine transfusion of red cells and platelets, and so on. Then patients at risk for developing transfusion-associated graft disease, so recipients of the allogenic stem cell transplants are also at risk from time of initiation of conditioning chemoradiotherapy until the GVHD prophylaxis has been started. So following stem cell transplant, and if chronic GVHD is occurring, so it is advisable to give irradiated blood components, which is the first line indication for irradiation. So patients undergoing bone marrow or peripheral blood stem cell harvesting for future autologous transplant should receive irradiated cellular component therapy during or for 7 days before the harvest and afterwards as well. And all patients undergoing autologous bone marrow transplant or peripheral blood stem cell transplant from initiation of the conditioning chemoradiotherapy until 3 months post-transplant should receive irradiated blood products, and 6 months if total body irradiation has also been given to the patient. So some patients who are not at risk are solid organ transplant recipients, solid tumors, routine surgery, non-Hodgkin lymphoma, HIV patients, premature or terminal infants unless the previous IUT has taken place. So what would be the clinical presentation in the case? Signs and symptoms usually begin within 4 to 30 days. So it would initial fever with skin manifestations, GI manifestations, hepatic dysfunction, bone marrow failure with pancytopenia. So then these are the skin manifestations like erythematous macropellar rash, pruritus, which will involve the palms and soles and spread throughout the bodies, blisters and ulcers in severe cases. So differential diagnosis would be with acute seroconversion illness due to HIV infection, acute viral hepatitis can also present with similar illness, severe drug reactions, dengue fever and leptospirosis. So it is probably an underdiagnosed since it may wrongly be attributed to other differential diagnoses. So in the histopathology of skin, we'll see exocytosis of lymphocytes, apoptosis at the basal epidermal retipex, satellite lymphocytes adjacent to the disc keratotic epidermal keratinocytes. In GI manifestations, diarrhea, secretory with volumous, which can be as large as greater than 2 liters per day, bleeding, life-threatening intestinal hemorrhage can also occur, abdominal pain, and in the histopathology, lymphocyte infiltration and apoptosis of the epithelial cells. In the liver manifestation, jaundice and hepatomegaly, increased liver enzymes, increased serum bilirubin. So how we detect these donor lymphocytes to come to a diagnosis of TAGVHD? This is by HLA typing and chromosomal differences, DNA fingerprint between the donor and the recipient, the detection of small genetic differences pre and post transfusion blood samples, bone marrow, affected and non-affected skin. So all this can help in including the diagnosis. So as compared to GvHD, why it is important to understand that TA-GvHD is more fatal? Because pancytopenia almost always occurs in TA-GvHD. Median onset is 10 days, 2 to 30 days. Fever usually occurs. Response to therapy is rare, and mortality is 90 to 100%. Whereas in hematopoietic stem cell transplant induced GvHD, the response to therapy is 30 to 50% and mortality is 10 to 20%. So it is less as compared to the then transfusion-related adverse events at the tertiary. So this is an Indian study from our center. So in which TA-GvHD is a rare event. So 1 out of total 300 reactions that was studied were found, and a case report has been reported from a institute. Then another hemovigilance program from India, in which analysis of reactions were done from 2013 to 2016 for 3-year period, and only one patient was reported with GvHD with underlying sepsis, and there was no supportive diagnosis. So there are few case reports from India and from abroad as well. So what is the treatment? It has a very poor prognosis, almost invariably fatal. Treatment options include high-dose steroids, anti-thymocyte globulin, azathioprine, methotrexate, cyclosporin, intravenous globulin, and hematopoietic stem cell transplant is the main solution. And ECP has not been tried in GvHD, TA-GvHD, but in acute GvHD and chronic GvHD. So coming to prevention, blood irradiation is the solution to prevent and inactivate donor lymphocytes. It occurs through cross linkage of DNA and prevents the TA-GvHD. So effects of irradiation on red cells are also there. Although GvHD is a preventable disease, but optimal prevention strategies should exist. Universal blood irradiation will eliminate GvHD, but it is not feasible at all the institutes or various depending on country to country. So a targeted approach only irradiate blood to be transfused at patients at risk. Prevention is by gamma irradiation, and X radiation can also be used. So it has a less initial cost and less radiation hazard, but more maintenance is required for X radiators. So this is a study from UK in which 50% mortality was reported over a period of around 14 years, and in US FDA during 150 million cellular blood products that were transfused, only 3 cases were reported. So this is because of the less mortality because they are using universal irradiation. So what are other leukocyte reduction options? So photochemical treatment is another good option, in which Sorolin S59 and UV arrays have been studied to reduce the transmission of infectious agent and may have added a benefit of TA-GvHD prevention. So this is a study which is comparing representation between reduced immune status of the recipient and risk for developing TA-GvHD. So in a compromised host, the risk is high, and compared to leukoreduction, pathogen reduction has been studied to cause a more protective mechanism to prevent TA-GvHD. So this is another study in which the pathogen reduction technology Intercept was used compared to gamma irradiation, and it was observed that pathogen reduction by Intercept caused greater than 6.2 log reduction of the T lymphocytes. So thus preventing would have a more preventive effect in TA-GvHD. So these are various studies in which mild atypical symptoms have been reported in TA-GvHD as well. And this is a systemic review in which various indications were studied for TA-GvHD, and it was noted that 65% of the patients who had no diagnosis conferring immunocompromised state were being reported as TA-GvHD. So it can occur in immunocompetent host as well. So coming to the summary of TA-GvHD, so sufficient number of viable T cells, that is 10⁵ to 10⁷, transfused into a susceptible host can cause this fatal reaction. Then immunodeficient states, either inherited or acquired, as well as recognized as a risk factor. And can develop within days of transfusion and follows a fulminant course of severe pancytopenia and infection. So disease is generally recognized by classical features of fever, rash, diarrhea, liver dysfunction. Irradiation is a highly effective treatment, and pathogen reduction technologies can also be tried as newer and more effective option for prevention. So word about transfusion-associated microprimarism. So in transfusion-associated microprimarism, a condition that occurs after transfusion of cellular blood components in which donor allogenic lymphocytes proliferate within the host and remain detectable for years, and they do not have any clinical sequelae. And as much as 2 to 5% of the circulating leukocytes were chimeric, and the distinguishing factors that influence T lymphocyte engraftment result in either resulting in Gvhd and sometimes not resulting in any disease. So it is subject of ongoing investigation. So there is a study in Vox Angus 2007 which stated that microprimarism resulted in release of IL-4, IL-10, TGF beta from Th2 lymphocytes. So these have been shown inhibiting the product of Th1 inflammatory response and deactivating the cytotoxic T lymphocytes, thus suppressing the rejection and causing microcan. Then coming to transfusion-related immunomodulation. So when we are transfusing a patient, especially a transplant patient who is immunocompromised, so there are various effects that can occur and are included in transfusion-related immunomodulation. So I'll be discussing these under these subheadings. So coming to TRIM, how it is defined. It can be defined as a variety of laboratory immune aberrations that occur after allogenic blood transfusion, and they're established or perpetuate clinical effects. These would include immunomodulatory effects, pro-inflammatory effects, and anti-inflammatory effects. It can either be by alloimmunization or reducing the tolerance. The presence or absence of autologous HLA-DR antigen on the donor WBC plays a decisive role. Fully mismatched HLA-DR antigens cause alloimmunization, and at least one HLA-DR antigen shared would cause the tolerance. So this is from the textbook of Rossi. So documented immune alterations which occurred with allogenic blood transfusion: decreased T helper cell count, decreased helper suppressor T lymphocyte ratio, then decreased lymphocyte response to mitogens, B cell activation, T cell activation, decreased cytokine production, suppression of the lymphocytes blastogenesis, then postulated mechanism which cause strain, clonal deletion of specific lines of immune cells, induction of suppressor T cells, suppression of natural killer cells, selection of non-responder type of immune cells, mixed microprimarism, induction of apoptosis resulting in death of specific type of immunocompetent cells. So coming to, so what is the residual number of leukocytes that are desired in the blood component? And so as per in RBC, we have desired is less than 5 into 10⁶ leukocytes, and as per the acceptable standards from European Council, per unit less than 1 into 10⁶ WBCs we call as leukoreduced, and in Indian standards less than 5 into 10⁶ WBCs per unit. So what are the various mechanisms by which transfusion-related immunomodulation is occurring when allogenic blood transfusion is given? So it is because of the allogenic WBCs, soluble biological response modifiers present in the blood, soluble HLA peptides in the plasma, and ABT itself predisposing to infection. So this can lead to various pro-inflammatory and downregulation of immune system. So this is a detailed mechanism of TRIM in by cell-associated mechanisms. So here the donor dendritic antigen presenting cells which are reduced in the antigen presenting in the allogenic blood, they cause they interact with the recipient T cells. There is a soluble HLA molecule which interacts, so which by co-stimulation further leads to recognition of recipient T cell of the HLA-DR antigen, which cause the immunosuppression. Microprimarism effect also occurs, which also causes immunosuppression. And if it is non-recognized, it will cause immune activation and rejection of this donor T cells. So if immunosuppression is occurring, it would cause allograft tolerance. So soluble HLA class 1 peptides circulating in the allogenic plasma, then soluble biological response modifiers in a time-dependent manner. So these would include basophils, eosinophils, neutrophils releasing various bioactive substances like histamine, serotonin, eosinophil protein X, myeloperoxidase, elastase, which have various different mechanisms as per the uh, previous studies which have been done. Then RBC unit. So this is another review article from Transfusion which shows that WBCs are there, RBCs and platelets in the RBC unit. So WBCs, which either it could be intact WBCs or soluble fast ligand, TGF beta or HLA molecules. Then in RBC, cell-free heme, iron, ubiquitin, which are also postulated in TRIM effects. And platelets would have bioactive lipids, extracellular vesicles. So all these would have an effect on the recipient immune cells, causing inflammatory effects, which could lead to alanization, neutrophil activation, monocyte activation, and inflammatory cytokine releases, and immunosuppressive effects, which could cause increased anti-inflammatory cytokine release, decreased neutrophil function, immune cell apoptosis, T cell energy, and impaired proliferation. So what's in our blood which causes the TRIM? There are various.
2 minutes more. 2 minutes more, Dr. Lamba.
Red blood cells, platelets, bioactive lipids, storage, processing, donor characteristics, and recipient characteristics would also affect. So coming to, so this is another study which shows that a normal immune response in which effector T cells are activated in the recipient when the donor APCs are given in the T cells, interact with the T cells of the recipient. Whereas in the stored blood, this immune response is decreased and energetic T cells are produced. So this is another study which shows suppression of the macrophage function and fast ligand in the blood component causing infected cell that does not undergo apoptosis. So potentially vulnerable populations are post-operative trauma, sepsis, cardiopulmonary bypass, transplantation, and deaths. So what are the clinical effects? So there are beneficial effects of this and deleterious effects as well. The beneficial effect through which is enhanced survival of renal allografts, reduced risk of recurrent spontaneous abortions, and deleterious effects, increased resected malignancy, recurrence of resected malignancies, increased post-operative infection, increased risk of short-term mortality in cardiac surgery. This is a proven effect of TRIM. So it is also proven that leukoreduction would help in cardiac surgery patients in reducing the mortality and post-operative infection. So these are various studies which have shown the transfusion-related immunomodulation. So in this particular study, an RCT was conducted. Various RCTs have been studied, and some have shown no difference and some have shown difference by giving reduced allogenic blood components and shifting to autologous transfusions or pre-storage reduction of WBCs. So in cardiac surgery patients, when the patient is shifted to extracorporeal circuit, hypothermia, ischemic repeat perfusion injury occurs, systemic inflammatory response syndrome is there, and there are compensatory anti-inflammatory mechanisms. But when SIRS is more as compared to the CARS, so infection, MODS, and mortality would occur. So this is a proven effect of TRIM. So other effects I have explained in the previous presentation slide. And this is another study which shows the RBCs which have residual leukocytes and apoptotic cells, which would cause TNF beta and other cytokines and biological modifiers to be produced, then extravascular and microparticles which cause transfusion-related immunomodulation and would cause cancer growth and dissemination. So this is another deleterious effect. Post-operative infection and post-op mortality can also occur. So post-operative infection is increasing in this study with more number of units are being given. So here lies also the importance of patient blood management by which we can prevent these deleterious effects of blood transfusion. So increased short-term mortality, then so TRIM in ICU, given mixed results of both preclinical and clinical studies, it is tempting to conclude that TRIM does not exist, or if it does, the effects must be small as compared to other insults the patients are facing. So this is a review article from Transfusion which says this. And what about the leukoreduced blood? So leukoreduction would help in CMV reduction, Epstein-Barr virus reduction, HLA immunization prevention, and bacterial and parasite contamination prevention. Pre-storage leukoreduction.
Please conclude, Dr. Lamba. Conclude your talk.
Just 2 minutes. So in this study, in which TRIM prophylaxis was used and pre-storage leukoreduction or post-storage leukoreduction was used as compared to the non-leukoreduced cells. So infection and mortality was less as in the leukoreduced PRBCs. Mortality was twice as high in buffycoat depleted as compared to lower infection with pre-storage leukoreduced products. And length of hospital stay also reduced in the pre-storage leukoreduced products. So summary of TRIM. So TRIM results in at least one established beneficial clinical effect and other unconfirmed deleterious effects. It remains unclear whether deleterious clinical TRIM effects by allogenic blood transfusion truly exist and whether they are mediated directly or indirectly by allogenic WBCs. In theory, pre-storage WBC reduction may lead to prevention of these TRIM effects, but still unproven, and that leukoreduction would improve the mortality and morbidity. And the available RCTs have not demonstrated a benefit from autologous blood transfusion in preventing these adverse TRIM effects. So I thank you for giving me the opportunity to present on this forum and your patient listening.
Thank you very much, Dr. Lamba. Very nice talk. I wish we had more time. Now we would move to the last speaker. I would give the microphone to Dr. Sharma.
Thank you, madam. I think next speaker is Ms. Rawan Aldubaian, the medical technologist and presently working in stem cell and cord blood banking, Department of Pathology and Development Medicine, King Faisal Specialist Hospital and Research Center, Riyadh, Saudi Arabia. So I would request Ms. Rawan to please present her experience regarding stem cell. His presentation.
Yeah, she's just preparing her slide. One minute.
Okay. She's from your center, madam?
Yeah, actually, she's with me in the office.
That's great. That's great. That's great.
Can you allow her to unmute?
Yeah, sure. Yeah. Dr. Akash, please.
Done, ma'am.
Thank you.
Can you hear me?
Yes,
Loud and clear.
Yeah, we can hear. A little louder, please.
Okay. So thank you very much for allowing me to present a case study for you today of an unexpected severe anaphylactic reaction to a stem cell infusion that happened in King Faisal Specialist Hospital back in 2020. So first, let me give you an overall patient history. She was a 6 years old female diagnosed with acute myeloid leukemia, the megakaryotypic cytic, and she started chemotherapy as per AATM L0531. Her minimal residual disorder post-induction 1 showed 4 to 6% blast. However, she had negative MRD after intensification 1. So they had planned for her to have the bone marrow transplantation, and they did cross-match with her family, and she was fully matched with her younger sister. After that, she started her receiving her conditioning regimen. So on day 0 of the cryopreserved allo bone marrow transplant, she was doing well, and her signs and symptoms were within the normal limits, and pre-medications were given, like the diphenhydramine and the hydrocortisone and the painkillers. A few minutes after starting the infusion of the cryopreserved allo bone marrow bag, she developed severe anaphylactic shock characterized with coughing and desaturation and decreased level of consciousness and unrecordable blood pressure, but with weak peripheral pulse. Code blue was activated and infusion was immediately stopped. She was resuscitated and transferred to PICU. Of course, 3 epinephrine doses were given, 2 IVF fluids boluses, and 2 Benadryl doses, 1 pre the infusion, 1 during the code, as well as 2 doses of hydrocortisone and 1 dose of Ventolin. So as we said, patient was transferred to PICU for close monitoring, and she was suspected to have a severe Dmso allergy or anaphylaxis. Of course, the side effects were treated and the vital signs were back to normal limits. So they had decided for her to have another bone marrow, fresh bone marrow transplantation from her haplo-identical brother. Currently, the patient is alive and well. She is 5 months post haplo-identical fresh infusion. Although she developed acute Gvhd of the gut, but she is receiving an outpatient treatment. Therefore, she is stable and alive. And now, after the incident, a morbidity and mortality committee meeting was formed and the case was discussed. And it was suggested to decrease Dmso concentration from 10 to 5%. Now, the international standard for stem cell cryopreservation Dmso is 10%. However, some infusion centers have been successfully using the 7.5 and even the 5%. Now, what is the Dmso or dimethyl sulfoxide? It is a highly polar organic liquid chemical solvent that appears as colorless and odorless. It's used to protect the cells and tissue during cryopreservation from crystallization and hence damaging and killing the cells. Dmso is mostly excreted through the kidneys, but a small part is excreted through the lungs and liver. Dmso has been proven to be toxic and has side effects like causing a variety of adverse reactions that are mostly transient and mild, such as flushing, dyspnea, abdominal cramps, and cardiovascular reactions. It may induce histamine release, which can be the reason for adverse reaction. Now, the dose of Dmso plays an important role in the occurrence of adverse reaction. However, it seems to be safe to use in small doses, like whether we use the 10% or the 5%, it's still considered to be safe for use. Part of the Dmso is transformed to the volatile metabolite dimethyl sulfide, which gives a characteristic garlic or oyster-like smell when excreted through the lungs. Hence, sometimes during the cryopreserved infusion, some patients complain from like a garlic aftertaste in their mouth. So we started conducting a non-inferiority study for validating the 5% Dmso by freezing 10 excess fresh hematopoietic stem cells intended for discard using different sources, like the bone marrow, peripheral stem cells, and cord blood. Of course, with using both 5% and 10% Dmso concentration. After that, we would compare the viability of the crude and post-thaw bags cryopreserved at the 5 and 10% Dmso concentrations side by side on 3 times intervals, 2 weeks, 4 weeks, and 8 weeks to ensure cellular durability. Now, what we expect is that choosing less Dmso concentration would maintain the same viability percentage we get from the 10%. However, it's still too early because we're still in the early stages of the study, but we have some unexpected preliminary result which showed that the 5% viability was even better than the 10% Dmso. And we hope to reducing the Dmso concentration to reduce the Dmso-related reactions, and we would be able to infuse more cryopreserved stem cells per session due to a lower Dmso volume per bag. Now, what do I mean by that? Let's say we have a 10 kg patient planned for cryopreserved stem cell infusion, and that the dose they need is 4 million per kg. Now, as you know, we freeze our stem cell according to the total nucleated cell in the product. So let's say, according to the TNC, we had to freeze our total dose into 2 bags, aliquot it into 2 bags. So then each bag would have 2 million per kg per bag. And 10% of Dmso in each bag means we have 8 ml of Dmso in the bag. And we have a policy that indicates that patients must only receive 1 ml of Dmso per 1 kg in a day. This means that the 10 kg would be less than the 16 mLs of Dmso in the 2 bags, and it would be unacceptable to give the full dose on day 0. However, if we start using the 5% Dmso, this means we would have 4 mLs of Dmso in each bag. So then the patient would be able to take the full dose on day 0, because the 2 bags would have 8 mLs of Dmso, which is less than her weight. So this brings us to the last slide. Again, thank you very much for allowing me to present this case study for you today.
Thank you, Ms. Rawan, I think, for bringing out this nice adverse event during stem cell transfusion. I think this is quite important that one must be aware that such kind of reaction can happen, and even people sometimes, if there is excess of Dmso, they try to practice washing, but at the same time, then you may lose stem cells, and then you may end up may not be able to get any close. But yes, I think, and people have tried 5% versus 10% also in the literature, and the results, as you said, are more or less the similar. I think they found the viability and the quality endpoints, they were more or less similar, and like with 5%, they end up transfusing less amount. So thank you very much again, and this was a nice presentation, especially for the newcomers, our young cellular therapy experts who wish to use up this area. And now I thank the organizers and hand over the mic to the organizers for further proceedings.
The session is now open for question, answers, and discussion. I would request the questions to be directed towards the chairpersons or the speakers. The chat box has so far received 2 questions. The first question is from Dr. Johan Garcia, and the question is for Professor Madrigal. Sir, if you will be kind enough to ask the question in person.
Could you tell me the question?
Yes, I want to start the discussion with a question regarding stem cells and transfusion. So my first question is very general. Dr. Madrigal, do you think it will be possible in the next future to develop red blood cells from stem cells or IPS, eventually for clinical purpose?
I think it's a very good question, because we have seen a major contribution of Yamanaka's sorts of original experiments in transforming cells into IPS. And since then, obviously, we had the hope that we would be able to produce elements that come from any cells to differentiate it into CD34, and from there differentiated into blood components such as red cells or megakaryocytes, and producing red cells and platelets. That has been done actually, but not yet to the point of clinical practice. However, many protocols have been generated that are very promising. And I think there is no doubt that this is a line that will come in the future. Already, for instance, there are already some clinical trials with the NK cells differentiated from IPS that can actually go through clinical trials by differentiating these NK cells, even to make CAR-NK cells. Already there are some groups and companies doing this in the United States and other parts of the world. So as I say, I'm very optimistic that this will be the case, just establishing the protocols and a reliable product. There are some difficulties still in red cells in terms of quality, productivity, capacity to generate the association with oxygen, but I think, as I say, they are very promising.
Thank you.
Thank you for the question.
I think Professor Madrigal's enthusiasm and optimism is what we look forward to for generating our own RBCs from the pluripotent stem cells. The next question is from Dr. Kalyan Roy for Dr. Divjot Singh Lamba. Dr. Kalyan wants to know, can immunocompetent patients develop transfusion-associated graft versus host disease? Dr. Divjot. I would ask the chairpersons the same question, if they would want to step in.
Yes, of course. Yes, it can happen in a transfusion-associated graft versus host disease. Can happen in immunocompetent person if they receive a blood from a relative or unrelated person. By chance, they share the HLA, so they can have an immunocompetent transfusion relay. That's why we irradiate all the blood for those patients. Thank you.
Thank you, ma'am. The session is open to discussion. All the participants are encouraged to ask questions. If there are any, the participants can just unmute themselves and ask questions. Dr. Kalyan Roy, please unmute and ask yourself.
Thank you, sir, and hello, everyone. I also have another question regarding transfusion-associated graft versus host disease. And I'd like to know much more about one-way HLA match. Can anyone please explain what is this?
Dr. Divjot, have you joined us back?
Divjot, are you there? One-way HLA match is basically if the recipient is homozygous for a certain HLA trait, right? And the donor is heterozygous for that trait. So since the recipient is homozygous, and one of the alleles in the donor would be similar to as that of a recipient. So recipient will recognize donor cells as self, whereas the donor cell, since it is a donor cell, donor is heterozygous, so donor cells will not recognize the recipient as self. So it is just the donor cells which are going to go into the recipient. The recipient will not throw them off. So they will have an opportunity, the donor cells will have an opportunity to proliferate in the recipient, as Divjot has highlighted, in various rapidly proliferating organs like skin, GI tract, bone marrow, right? So they will go and home in all these areas, they will proliferate and mount an immunological response in the form of TAGVHD. So this is what is known as one-way HLA match, basically. So one-way means recipient is homozygous for one of the alleles in the donor. Yeah. Is that clear? Hope is that I could make it clear.
Yes, sir. Thank you. Thanks for
indeed, very crystal clear indeed.
Yeah.
So just to get an international perspective on the directed donation amongst the first degree relatives, I would bounce off this question to Dr. Johan Garcia. What are the practices in your setup for directed donations from first degree relatives to the patients in order to avoid this kind of transfusion associated graft versus host disease?
Well, if I understood well, the question is, what is the prophylaxis of GVH in transfusion medicine in our situation?
Yes, exactly.
Yes, we do irradiate. We do irradiate all the products which are defined to be transplanted to immunocompromised patients. So in our facilities, we have irradiation devices, technologies, and other products are submitted to irradiation. It has been working for a long time. So this is our routine.
Thank you, sir. I would like to have a comment from Dr. Hind Al-Humaydan, ma'am, regarding, do you discourage or avoid donations from first degree relatives to avoid TAGVHD?
Not at all. As Professor Lopez mentioned, we irradiate the blood. And actually for societies which are like homogeneous societies, they share the HLA, like what we have in the central part of Saudi Arabia, or the papers came really from Japan, where it is somehow homogeneous societies. You can share an HLA with a non-relative. So in my center, because we're a tertiary care center and we're a transplant center, I irradiate for almost everybody, except the OR cases where the percentage that the blood will be used is very low. The blood will come back to me. I don't irradiate, but I almost irradiate for everybody. So there is no harm if a directed donation comes from a first-degree donor, provided you don't miss irradiating the unit. Thank you.
Thank you, ma'am. Is there any other question? I can see Dr. Kalyan Roy has raised his hand.
Yes, sir. I have another question regarding graft versus host reaction.
Please go ahead.
Okay. Does solid organ transplant patient needs irradiate blood or not?
So just to make it clear the question, please, ma'am, please take the question, ma'am.
The answer is yes. We had graft versus host disease, one case post-liver transplant. So yes, patient who receive liver or solid organs, yeah, it's better to irradiate, safer. Heart transplant also.
Thank you, ma'am. And I have just another last question regarding this graft versus host reaction, and that most of the patients or even the patient party also just asks us whether the irradiated products are radioactive or not. So what will be our answers to them?
No, they are not. They are not. Even the irradiator in the blood bank, it doesn't, I mean, it's very safe, provided you keep every 6 month dosimetry and, you know, because it's totally, the radioactive source is totally shielded. So it is not radioactive, not at all.
Yeah, that's right. So I think for that, you need to understand the mechanism, how the radiation affect these T cells. You see, they go and affect the genetic material within the viable T lymphocytes. So they make them inactive, rather cause the adduct formation or some cross-linking in the DNA, in the DNA of these T cells, and then they render them ineffective or cause apoptosis also. So this, I mean, does not harm, or this does not have any sort of radioactivity in the product. So that's that should be clear. I think I mean, not have any, as madam has already cleared that it does not contain any radioactivity or anything to do with that. But yes, you need to have a regular quality check of your equipment, because in terms of the handlers basically and the premises, your technical staff or the who regularly handles the equipment, because he or she need to have a badge whenever, as and when they go to handle this equipment, and that badge has to be assessed quarterly and sent to a quality lab where they assess the exposure. So it is very important that you need to have that quality practice in place, so that you don't harm your users. Otherwise, it is perfectly well said that this source is in the properly shielded, and it hardly have any concerns of exposure. Thank you.
Thank you, sir. A question for Dr. Delgadillo. Sir, how far are we from a routine usage of mesenchymal stem cells in the treatment for COVID?
Okay, so thank you very much for the question. I mean, if you have followed my presentation, you have seen that there is almost 90 clinical trials registered in international registries, and there are very few clinical trials published. And clinical trials that are already published are of limited sample size. So this means that we are not yet there. With regards to the biggest clinical trials that are ongoing, the biggest one was the clinical trial sponsored by Mesoblast, that is a US company. This study stopped the recruitment based on the advice of the Safety Monitoring Board because of the mortality seen within the trial was below the expected, so there was a very low chances to detect any difference in mortality. But the DSMB board recommended the follow-up of patients up to 60 days and to assess the effect of mesenchymal stem cells in secondary endpoints. The results of this secondary analysis has been presented at the last ISCT meeting, and if I remember well, the mesenchymal stem cells worked on the youngest population, so this means people below 65 years old, and also in the patients that were less seriously affected by COVID. So this meaning patients on nasal oxygen and high flow nasal oxygen. But this is based on a post-hoc analysis on a study that has been halted. I know that there is another big one clinical trial running on in Pakistan that aims to recruit up to 600 patients, but as far as I know, there are no results published yet.
Thank you, sir. Now, I would request Dr. Johan Garcia for concluding remarks, sir.
Thank you very much. Can you hear me? Yeah. Thank you very much. I think it has been a very first attempt to collaborate with in a webinar with AATM. It has been an honor also and a pleasure. I think that this experience has been very constructive. We meet a lot of people. We met about 120 attendees, which is for me is a real success. I think this is the first time, and we'll continue doing more webinars. And I want to thank the speakers, the organizers, and also the attendees for devoting their time to this session. So thank you very much for your.
Before we have the vote of thanks from Dr. Anand Gunasekara, Secretary, ATM International, I would request all the participants who are there to please switch on their cameras. We'll have a virtual group photograph just to remember the good times by.
Thank you, Dr. Aikaj. It is indeed a great pleasure to deliver a few sincere words for the people, those who got involved in this very, very difficult exercise and a popular exercise as well. And this is a collaboration between AATM and BST. And may I get the permission from our president, Dr. Chowdhury, that is AATM president, and Dr. John Garcia, the director of research of BST, and of course, the two chairpersons of the session, Dr. Rati Ram Sharma and our good friend, Dr. Hind Al-Humaidan, to deliver these few words. Firstly, let me thank the lecturers, Dr. Alejandro Madrigal of Spain, the professor of hematology, for delivering the topic on cellular therapy, introduction. And may I also thank Dr. Joaquim Delgadillo of Spain for delivering the talk on cellular therapy in COVID times. And the next lecturer, Dr. Divjot Singh Lamba of India, for delivering the talk on transfusion-associated graft versus host disease and transfusion-related immunomodulations. And thank you very much for your very, very informative lectures. And also my thanks goes to for the case study presentation done by Ms. Rawan Aldubaian of Saudi Arabia. And I have to, in absentia, I have to thank Dr. Claudio Dufer. He's the chairperson of our the cellular therapy working group, who couldn't join due to the time difference between the South America and here. So my thanks goes to him also. He did a lot of work for us in the cellular therapy. And we cannot forget these two gentlemen, Dr. Aikat Jindal and Dr. Ankit Mathur, the two gentlemen who work around the clock with us whenever we have an activity like this. They are our technical coordinators, IT coordinators. They do a fantastic job coordinating every corners and getting the ATM in a very technical terms. Thank you, Aikat and Ankit. And finally, all the 115 plus participants, those who have participated in this event, and also those who have asked questions and those who have given the answer to the questions. And thank you very much from the ATM. And we like to do more of these activities. We don't care whether the COVID there or not. We are doing more and more. So please join with us in the future also. Thank you very much.
So as all good things come to an end, so must this. I would request the President, AATM, Dr. N. Chaudhary, to say a few words before we conclude, and that would mark the end of this webinar.
As Dr. Anand Gunasekara has said, my good friend, our first thanks goes to BST for signing MOU and joining Manpower and Quality Development Program with AATM. And secondly, we are grateful to both all the speakers and both the chairpersons, and special thanks to all the participants, because there is no seminar, no webinar unless there are participants. Thank you all. And thanks to our, again, the last Ankit and Aikas. Only problem was that this high tech sometimes creates problem and prevent me to join you for half an hour because we are both of us were host. Okay, but if it is a problem, we have to solve this problem. We have solved. We are with you, and this will be a routine activity. BST and AATM, and we are probably going to have at least 3 per year. And I'll leave it to John and to organize. Thank you, everybody. Thank you very much. Okay.